welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Thank you everyone for joining the October ACCP EMED PRN Journal Club. Today we have Hanine, who is a PGY2 critical care resident at King Faisal Specialist Hospital and Research Center in Saudi Arabia. She will be presenting a journal club on acetaminophen for prevention and treatment of organ dysfunction in critically ill patients with sepsis, the ASTER RCT.
I have no real or potential conflict of interest to disclose related to the subject presented. As for the objectives of this presentation, first we'll discuss the available evidence regarding acetaminophen, sulfur hemoglobin, and their interaction with sepsis. We'll examine the ASTER trial methods and results. And finally, we'll summarize the study conclusions and their applicability to clinical practice. So acetaminophen is one of the widely used medications in general in clinical practice and at outpatient settings. Its exact mechanism of action is still unknown. However, it's hypothesized to exert its analgesic activity through central activation of descending serotonergic inhibitory pathways. It's also thought to exert its antipyretic activity through inhibition of the hypothalamic heat regulatory centers. It's available in many dosage forms to offer flexible administration options. As for its role and place in therapy in critical care settings, there are many meta-analyses that investigated its role. First, in its role in temperature control and as an antipyretic medication, there was a meta-analysis of 13 randomized clinical trial published in Journal of Critical Care Medicine in 2021, which included 2,000 patients who were non-neurocritically ill patients with fever due to sepsis. So they found in this meta-analysis that the interventions, including acetaminophen, non-steroidal anti-inflammatory drugs, and active cooling methods, significantly reduced body temperature from baseline. However, when they looked into other outcomes such as 28 days mortality, length of stay in the ICU, and shock reversal, none of them showed any significant benefit. So the authors concluded that antipyretics do lower temperature, but without affecting mortality in this subset of patients. And due to limited evidence, fever treatment in critically ill patients should be individualized. In light of these findings of the meta-analysis, the Society of Critical Care Medicine and Infectious Diseases Society of America published a guideline evaluating new fever in adult patients in the ICU, and they issued 2 recommendations in this regard. First, they issued a weak recommendation suggesting to avoid the routine use of any antipyretic medications for the purposes of reducing body temperature. And they also issued another recommendation, which was weak, to offer antipyretic medications in those who value comfort by reducing temperature. As for the other place of therapy, its role in analgesia in general, the PADIS guideline in 2018 issued a conditional recommendation suggesting the use of acetaminophen in particular as an adjunct to opioids to improve pain management in the ICU. And this was in light of the findings that acetaminophen, when added to other opioids, improved pain control through pain intensity reduction at rest using the VAS-H scoring scales. Also, it reduced the opioid consumption measured by morphine equivalents. Also, they looked into other outcomes such as time to extubation, sedation requirements, as well as rates of nausea, all of which were reduced when acetaminophen was added to opioids. The authors also raised a safety concern for hypotension, mentioning that up to 50% of patients may experience the side effects, with a reduction expected of less than 15 millimeters of mercury, which may limit its use in some cases. And since we mentioned acetaminophen and hypotension, it's worth noting that the side effects been first observed by nurses who noted increased vasopressor requirements after the administration of intravenous acetaminophen. After which there are multiple observational prospective studies as well as randomized trials exploring the side effects, which further solidified these findings, linking acetaminophen administration to hypotension. Its exact mechanism is thought to be linked to the acetaminophen metabolites, the N-acetyl P-benzoquinone, which causes the activation of voltage-gated potassium channels at endothelial cell levels, leading to vasodilation and hypotension. This side effect is thought to occur more frequently in the intravenous formulation compared to the oral ones, and it typically occurs within 15 to 60 minutes post-infusion. There are many populations who are highlighted as high-risk patients, most importantly, febrile patients and those with sepsis. As for cell-free hemoglobin, acetaminophen, and sepsis, the core of our presentation, so sepsis causes damage to the red blood cells membrane, causing the release of cell-free hemoglobin to the circulation. These molecules has been linked to increased risk of adverse effects, mainly kidney injury, myocardial infarction, and even increased risk of death. It's estimated to be present in about 80 to 90% of critically ill patients with sepsis. So how does these molecules exert their negative effects? It's been hypothesized that these molecules cause scavenging of nitric oxide, inducing vasoconstriction. They also enhance inflammation by activation of neutrophils. They also damage the vascular endothelium and cause oxidation of lipid membranes, further increasing oxidative injury. Acetaminophen, which is the star of our show, is thought to mitigate the effect of cell-free hemoglobin through the inhibition of the oxidative pathways. So the first exploration of the relationship between all three, cell-free hemoglobin, acetaminophen, and sepsis, has been published in 2013 in Critical Care Medicine. It was a retrospective observational study of about 400 patients who were critically ill with sepsis. It was conducted in multiple ICUs within a tertiary academic hospital. They looked into two things: the link between mortality and cell-free hemoglobin and acetaminophen. As for the interaction between cell-free hemoglobin and mortality, they noted that non-survivors had significantly higher cell-free hemoglobin compared to those who survived, with a mean difference of 10 milligram per deciliter. And they also noted an increase in cell-free hemoglobin to be associated with increased risk of in-hospital mortality with an adjusted odds ratio of 1. As for acetaminophen, they did find significant reduction in oxidative markers measured as the plasma F2 isoprostane, with a significant difference of 23.5 picograms per milliliters. And they also noted lower risk of death among those who received acetaminophen compared to those who did not receive it. And the difference was also statistically significant. This observational study prompted the design of this randomized placebo-controlled trial, which was a phase 2A. The same investigators who designed the observational study conducted this trial, including 45 patients who were critically ill with severe sepsis and detectable cell-free hemoglobin levels of more than 10. It was conducted at a single medical ICU. They randomized patients to receive either oral acetaminophen at a dose of 1 gram every 6 hours for 3 days. The other patients were randomized to receive placebo. The primary outcome was the reduction of oxidative injury as measured by the plasma F2 isoprostane. These were their baseline characteristics. Overall, they were around 50 years of age. 50% of them were males and predominantly of white race. The baseline SOFA score was around 6, indicating moderate severity of illness. What's worth noting here is the unbalanced clinical characteristics, including vasopressors, rate of ARDS, and levels of creatinine and the oxidative markers, all of which were significantly lower in the acetaminophen group compared to the placebo arm, indicating that acetaminophen group at baseline were less severely ill compared to the placebo arm. Additionally, the cell-free hemoglobin level were about half of the patients that were in the placebo arm, where it was 10 at the acetaminophen group compared to 20 in the placebo arm. As for the results of this phase 2A trial, they found significant reduction in the oxidative markers at day 2, which was statistically and numerically significant. However, at day 3, we can see from the presentation here that in the acetaminophen arm, the oxidative markers went back close to the baseline. Also, they looked into other outcomes such as kidney injury, and they found significant reduction in serum creatinine at day 3 and the reminder of the stay in the ICU, all of which were statistically significant. Finally, they looked into other outcomes, such as mortality, and while it didn't reach statistical significance, there were still trends toward lower mortality in the acetaminophen arm compared to placebo. And the authors concluded that in adults with severe sepsis and detectable cell-free hemoglobin, acetaminophen treatment may reduce oxidative injury and improve renal function. Which brings us to the trial of today, acetaminophen for prevention and treatment of organ dysfunction in critically ill patients with sepsis, the ASTER randomized clinical trial, which was published in JAMA in late May 2024. So this study was a phase 2b randomized double-blind clinical trial involving adult critically ill patients with sepsis and respiratory or circulatory organ dysfunction. They randomized patients either to receive intravenous acetaminophen at a dose of 1 gram IV every 6 hours for 5 days or until ICU discharge, whichever comes first, or matching placebo, which consisted of 100 ml of dextrose in water every 6 hours for 5 days or until ICU discharge. This study was conducted in 40 US academic centers with enrollment from 2021 to 2023, and a median follow-up of 90 days. Primary outcome was days alive and free of organ support, including dialysis, assisted ventilation, and vasopressors up to day 28. It's important to note that this trial was initially designed as a 3-arm study to include acetaminophen, vitamin C, and placebo. However, the vitamin C arm was later discontinued in June of 2022 after enrolling about 80 participants due to external trial data, mainly linked to the LOVIT trial. Other outcomes measured in this study included efficacy, mainly ventilator, vasopressor, renal replacement, ICU, and hospital-free days. They also measured major adverse kidney events at day 28, change in SOFA, development of ARDS, and mortality. As for safety outcomes, they looked into elevation of liver enzymes and hypotension. And they looked into other exploratory outcomes, such as the utility of pre-enrollment point-of-care measurement of plasma cell-free hemoglobin for predictive enrichment in future phase 3 trials of acetaminophen in sepsis. Inclusion criteria included adult patients with sepsis defined by suspected infection and antibiotics administration, and required vasopressor support after at least 1 liter of IV fluids, or respiratory failure as indicated by the need for mechanical ventilation, non-invasive ventilatory support, or 6 or more liters per minute of supplemental oxygen. Also, they required the patient to be admitted to the ICU within 36 hours of presentation to the ER or acute care hospital. Key exclusion criteria include hepatic impairment marked by cirrhosis, liver transplant, or any elevation in ALT/AST of more than 5 times upper limit of normal. They also excluded those with chronic alcohol use, defined per their screening tool, assessing the frequency of alcohol consumption. According to the screening audit, if the total point is 4 or more, the patient is excluded from the study. They also excluded those on chronic dialysis or receiving home-assisted ventilation. As for study procedures, the study was blinded to patient, nurses, research staff, and physicians, and the medication was transferred to sterile containers prior to dispensing by pharmacy. The study was supported by grants from the National Health, Lung, and Blood Institute, which didn't play any involvement in the study design, data interpretation, or submission of the manuscript for publication. Cell-free hemoglobin was measured on days 0, 2, and 3 using point-of-care testing. However, the exact method of testing and measuring cell-free hemoglobin was not indicated. They also measured the ALT and AST at the first week of therapy, with this permanent discontinuation of the study drug if any new elevation of more than 10 times upper limit of normal occurred. Finally, the study drug was also discontinued if any of the following occurred, including discharge from hospital or ICU, withdrawal from the study, or death. As for the statistical plan, they estimated the sample size of 218 participants per group would provide the study 85% power to detect 2.5 difference in primary outcome, mainly days alive and organ support free. This difference of 2.5 was extrapolated from the findings of the Clover trial, which was published at that time, comparing the liberal versus conservative fluid resuscitation strategies in patients with sepsis. Other statistical tests that are worth mentioning include the 2-sample t-test, which was used for the primary outcome, and they used the ANOVA for the continuous outcomes and generalized linear model for the other binary outcomes. A p-value of less than or equal 0.05, which was considered statistically significant, and the primary outcome was analyzed according to the intention to treat approach. Finally, they used a baseline of cell-free hemoglobin of more than 10 to predict improvement in organ support and mortality. Coming to the study results, out of the 4,500 patients screened for possible enrollment, they excluded 3,500 patients. They first excluded the vitamin C arm, which consisted of 40 patients, because as we mentioned earlier, the study was initially designed as a 3-arm study involving vitamin C. But because of the publication of other trial data, they elected to remove this study arm. They also removed those patients presenting with the liver or kidney impairment. And which was worth mentioning is that they excluded those patients with active kidney stones. This key criterion was not mentioned in their study protocol. However, it's possible they excluded those patients because of the initial involvement of vitamin C in the study, which has been linked to to the development of kidney stones. However, with the removal of this study arm, this impact now is less relevant to the study design. They also excluded those with respiratory assist devices at baseline, those with alcohol use disorder, and those presenting with diabetic ketoacidosis or require hourly glucose monitoring. While again, this wasn't specified in their pre-designed protocol, this might be done to prevent any impairment in blinding, since the placebo arm is receiving a dextrose of D5 water every 6 hours. So any continuous monitoring would lead to impaired blinding. Finally, they randomized about 900 patients due to randomization and prognosis factors. Now moving to the baseline characteristics of the study, they mainly included patients who are around 60 of age, 50% of them were males, and predominantly of white race. 75% of them had circulatory dysfunction, while 40% of them had respiratory dysfunction. Looking at other characteristics measured, ARDS at baseline was reported more in the acetaminophen arm compared to the placebo, where the acetaminophen had 18% compared to 13.7% in the placebo arm. Time to from inclusion to randomization was around 10 hours. The primary site of infection among the study population was mainly pneumonia and urinary tract infection. Tested positive for COVID, and it was around 10% across the study population. And they did some baseline measures, including creatinine at presentation and in the outpatient. And it shows that the patient presented with some degree of kidney dysfunction, which is expected for those presenting with sepsis. Other measures such as ALT, AST, bilirubin, and platelets were within normal limits. They also measured the SOFA score at baseline, which indicated moderate severity of illness of 5. However, it is worth mentioning that they explicitly provided in their supplementary material that they excluded the neurological assessment, the GCS, from the SOFA assessment. While this wasn't clearly justified in their material, many intensivists now are looking into questioning the GCS component of the SOFA assessment, since patients typically present with respiratory failure requiring intubation and sedatives administration, all of which would confound the GCS assessment. So this could be a reason for excluding GCS. However, when interpreting the total SOFA score, this should be kept in mind. Also, they looked into median cell-free hemoglobin levels, which were around 8. And 40% of the study population used pre-randomized acetaminophen, which may add some confounding to the results and treatment effect. However, it was well balanced across the study groups. Additionally, they didn't provide any definition of pre-randomization acetaminophen. For how long did they use it? How much did they give before randomization? This wasn't specified, but it is an important thing to note. As for the primary outcomes, when we look into days free of organ support in general, there was no difference. And this was consistent for any of the components that they looked into, including assisted ventilation, vasopressors, and kidney replacement therapy, all of which showed no difference in treatment effect. However, when we look into 28 days all-cause mortality, there seems to be trends toward lower mortality in the acetaminophen group compared to placebo, with a mean difference of 5%. However, this difference didn't reach statistical significance. They conducted a subgroup analysis looking into various groups that would show any benefits from treatment of acetaminophen, and they did find trends toward better days alive and free of organ support for those receiving pre-randomization acetaminophen compared to those who didn't. They also found trends toward benefits in favoring acetaminophen administration among those presenting with higher baseline cell-free hemoglobin of more than 10. However, it's important to note that none of these reached statistical significance. Looking into their secondary outcomes, we can see here that there was significant reduction in the development of ARDS during the first week of randomization in the acetaminophen group compared to placebo, with a mean difference of 6%, which was statistically significant. Other outcomes measures such as change in serum creatinine and MAKE at 28 days, none of them showed any positive results or any significant differences. What is worth noting here is that the 90 days all-cause, all-location mortality continued to show trends toward lower mortality in the acetaminophen group compared to placebo, with a mean difference of 5%. But again, this difference didn't reach statistical significance. They also reported any adverse events, but there was no statistically significant difference in the number of events reported. Here in the time to event analysis, they looked into days from randomization in the x-axis, comparing to the probability of survival and proportion of participants without organ support in the y-axis. And they plotted days alive at the top, and on the bottom, you can see the days without organ support highlighted in orange and gray. We can see the significant crossover, especially in the first 12 days. However, after 12 days of randomization, we can see clear separation in both study groups, showing trends toward more benefit in the acetaminophen arm in terms of survival or days without organ support. And this difference was consistent and persisted up to day 28 of randomization. They also looked into change of total SOFA score through the first week of therapy. And while it didn't show an overall difference, when we look closely into the days 2, 3, and 4, we can see significant reduction in the SOFA scores in the acetaminophen group compared to the placebo arm, which may signify some treatment benefit during this period. However, this treatment benefit tends to fade away after day 4. They also investigated separate SOFA components and their change over the first week, and they found significant difference across the groups in the respiratory and coagulation components. However, the other systems were unaffected. Other outcomes that they looked into was the trends of cell-free hemoglobin. While it wasn't different in both groups, the acetaminophen and placebo arms, there was trends overall of reduction of cell-free hemoglobin from day 0 to day 3, reaching up to 6 in both arms. As for the safety outcome, they measured the mean AST and ALT in the first week of therapy. And according to the reported values, there was no statistically or clinically significant difference, raising concerns for any liver injury caused by acetaminophen in this study. Additionally, they measured hypotension, where severe hypotension was defined as the need of IV fluid boluses of more than 500 milliliters, the need of new vasopressors, and or the increase in vasopressor dose within 120 minutes following the administration of the study drug. They noted only one event, which wasn't linked directly to the treatment, but it was deemed as probable and was treated successfully without any complication. Here, divided the groups according to the baseline cell-free hemoglobin, dividing the groups to a baseline of less than 10 or a baseline of more than 10. And they plotted it comparing the 28 days all-cause mortality rate. And we can see from this bar chart, there was more pronounced treatment benefit and reduction in mortality in favor of acetaminophen in those presenting with high acetaminophen cell-free hemoglobin level in the bars on the right. However, it's important to note that all of these interactions, it's been statistically non-significant. They also plotted the cell-free hemoglobin as a continuous variable against 28 days mortality and marking the hemoglobin 10 as a marker of comparison. And they found that while below 10, there was variable treatment effect for acetaminophen on mortality. When we look into after the dotted line, after a baseline of 10, there's significantly more prominent treatment effect in the acetaminophen arm compared to the placebo arm, suggesting that acetaminophen may benefit those most presenting with higher cell-free hemoglobin compared to those who present with lower than 10. So the authors concluded at the end of the study that intravenous acetaminophen was safe, but didn't significantly improve days alive and free of organ support in critically ill patients with sepsis. This study has many strengths, including being a multi-center randomized double-blind study. They included septic patients regardless of their baseline cell-free hemoglobin, further improving the generalizability of their findings to clinical practice, since we don't still measure the cell-free hemoglobin in clinical settings. They reached their target sample size for the primary outcome, and the use of exploratory biomarker analysis, which further enriched their findings. And finally, they did a rigorous endpoint evaluation that they should be applauded for. Coming to their limitation, the first limitation, which was addressed by the investigators themselves, includes that their patient received an average of 12 out of 20 planned doses, averaging 3 days of total therapy. Also, half of the study population were receiving acetaminophen prior to enrollment, which could add some confounding effect, which was then further supported by the subgroup analysis showing more favor in those who received acetaminophen pre-enrollment. Also, the intervention was given for less than 5 days, which may be too short to impact 28 days outcomes. Also, the study population presented with low baseline SOFA score relatively to what we see in clinical practice, which may limit the generalizability to those who are more sick. Finally, there was unclear validity of respiratory dysfunction outcome measured in the study. So key takeaways: while treatment with intravenous acetaminophen was safe without causing significant concerns of hypotension and liver injury, it didn't improve organ support 3 days. The observed trends in secondary outcomes warrant further investigations, and further exploration of potential predictive values of plasma cell-free hemoglobin in guiding acetaminophen therapy and sepsis management is needed. That's it for the study of today, and I welcome any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.